Hey guys, we're back. We're going live on a Friday afternoon, Facebook and YouTube. So just trying to make sure all my stuff is working here. So if you're jumping on and you can hear me and see me, let me know. Just put a chat in the comments there to say you can hear me or see me. And we'll get going. We'll start answering some questions. Okay. Looks like people are jumping on. Hey, Kimberly, how's it going? Let me know if you can hear me okay. I'm just trying to make sure everything's working like it's supposed to. And if anybody's there on Facebook that can hear me and see me, let me know how things sound. Make sure the video is working okay. And we'll get to answering your questions as soon as somebody puts one in the chat. So while I'm waiting to hear or to read some of your questions, I'll give you one little bit of latest information. I was just reading a study the other day that showed something that we probably all know, and that is that it's not a great idea to smoke while you're pregnant. And I think everybody knows that. There's definitely concerns about things like fetal growth restriction and things like that. However, this most recent study I was reading showed evidence of increased association with miscarriage and even stillbirths. And it was a substantially or a statistically significant increased risk. So just additional information out there to say, hey, you know what, probably not a good idea to smoke while you're pregnant. And that's probably not a big surprise to most people, but I think it's good information to keep in mind. If you have friends who are pregnant, who are trying to smoke, or who are trying to quit smoking, that's probably one of the most important things you could encourage them or try to help them do. Certainly any of the smoking cessation medications that we typically use are safe in pregnancy, particularly things along the lines of Wellbutrin, which has been around for a long time as an antidepressant, are frequently used for smoking cessation aids, nicotine gums and patches and things like that. They're all fine. And certainly getting on like the Utah Quit line, there's some online resources you can use that are also, I think, a good idea. So thanks, Jenny, saying it sounds like it's good there. If you have questions, guys, please put them in the chat so I can answer your questions. And looks like folks are jumping on YouTube as well. So if you're there, shoot a question into the comments and we'll get to answering them. So let's see. Can you? Oh, thank you, Shaylee, for a question. Can you have mastitis with the only symptom being tenderness? Possibly. Although I will say that most people who I've diagnosed with mastitis, it's pretty obvious. You typically have a pretty high fever, 102, 103, shaking chills, really feel just terrible. So if it's only tenderness, it's, I would say, not as likely to be mastitis. If there is redness over an area of the breast and it's tender and you've got like a low-grade temperature, or low-grade fever, then I'd say it's probably mastitis. But if it's just tender, no redness, no fever, I'd say less likely, but not impossible. So if you have continuing problems there, I'd say get it checked out. Okay, let's see. Heather says, when you have more than one child and pregnant, is inducing always an option or does it depend? I mean, for the most part, induction of labor is considered an acceptable option for anyone, whether it's your first baby or not your first baby. And that's mostly due to some recent data that came out of this study called the ARRIVE trial, looked at about 6,000 women, and these were first-time moms, and looked at the risks and benefits of induction of labor. And it turns out that induction of labor in first-time moms even resulted in a lower C-section rate in the group that was induced at 39 to 40 weeks. So that's kind of a safe time for anybody to be induced. And so whether it's your first time or not your first time, I think it's certainly reasonable based on that data to be induced if you choose to. And there are some, medical reasons why that might be a good idea as well. So short version, I think it's fine. There is a video on my YouTube channel that talks about that in a little more detail called, I think it's called Should I Be Induced? So maybe check it out. Let's see. Sarah, 16 weeks pregnant, horrible SI joint pain. Yeah, it's going to probably last all the way to the end, unfortunately. What can you do about it? Physical therapy, I have found to be one of the best things you can do for SI joint pain. That sacroiliac joint pain, for folks who don't know, it's typically kind of low back, usually one side or the other. And it's mostly due to the fact that the joints in your pelvis do relax a bit when you're pregnant, and that causes pain, usually at the site of the joints. So either the sacroiliac joints in your low back or around in the front, that's the symphysis pubis, and any of these can cause pain. And physical therapy I've found to be fairly helpful, so you might consider that. It's mostly about trying to get those joints back into alignment and then doing some core exercises to try to help keep things in alignment. So, check it out. Happy to make a referral for anyone, if one of our patients in the office, to a good physical therapist in the area to help out with that. And if you're somewhere else, then you can talk to your doctor about making that referral. All right, thanks everybody for the little happy faces and whatnot that are coming up on Facebook. That tells me that it actually works, so thank you. Okay, let's see. Jamie, chances of not ovulating even though you get a period every month. Had your doctor tell you to check your blood, see if you're ovulating during clomid. Guess you never ovulated. If you have, so if you had a progesterone level, say cycle day 21, that was 10 or higher, that would be evidence for ovulation. So if you had a level under 10, then I would think that would be less likely to be consistent with ovulation. But if you have positive ovulation tests, or if you have changes in cervical mucus, if you have, say regular cycles every 28 to 30 days, you probably are ovulating, and it might even be that the test was wrong. But if there's continuing questions about that and you're on clomid, what I would recommend is doing a follicle check with ultrasound around day 10 to 12. And if you see a follicle developing, then we could give a trigger shot just to make ovulation happen. And that works well for most people, especially if you're getting kind of confusing indications with blood tests or whatever. Let's see, Candace, I need to know how to take the medicine for Raynaud's. Can you explain what this is? So Raynaud's is basically like a vasospasm, so blood vessels that contract in the breast and cause pain with nursing. Not really well understood why that happens, but it happens. And nifedipine is a calcium channel blocker, which is it's a blood pressure medicine that works to help blood vessels to relax. So in theory, that should reduce pain. Typically taken about every 6 hours, kind of as needed. So that's how I would recommend taking it. I wouldn't take it much more frequently than that, only because it can lower your blood pressure, cause some dizziness, headaches, things like that. So hopefully that answers your question, Candace. Let's see. Carla says, losing weight can help you conceive, but what if only 5 pounds overweight? Does it still make a difference? Probably not. And then how much weight should someone try to lose, or what does this help with? It's mostly to do with ovulation, insulin resistance, things of that nature. And so if someone's really overweight, they tend to become somewhat insulin resistant, not 5 pounds. I'm talking, 15, 20% over ideal body weight. And then when you start to get insulin resistant, that's often where other symptoms of PCOS start to develop. And one of those is infrequent ovulation. So if you're not overweight, it's probably not that. There are people who do meet criteria for PCOS based on other findings, and obviously things like signs of excessive testosterone, so increased acne, facial hair. You can see blood values that are elevated. If you have ovaries that have the sort of classic polycystic ovarian appearance, then you could still actually technically still make a diagnosis of PCOS, even in a person who's not overweight. Let's see, but otherwise that's about it. And then if you're curious about other things to help you get pregnant, Carla, there's a video on the YouTube channel you're watching right now that basically is called something along the lines of how to maximize your natural fertility. So I would definitely check that out. And if you have questions after that, put them in the comments of that one, and I'll be happy to answer them. Let's see. Charlene says, what does progesterone of 65? So I don't know the units that they're reporting it in. It's usually 10 is, and I have to look it up in our computer to see what the units are. But if it's the same units, then if it's over 10, you ovulated. Sorry, I don't know that nanomoles per liter. So I would check with your doctor who ordered the test and ask them what those units mean in your lab system. All right. Let's see. Kimberly, is it true breastfeeding for the first 6 months is natural birth control? It's pretty decent natural birth control. And so if the WHO put out guidelines a few years back that basically said things like, if you're nursing exclusively, so no bottle feeding of formula, so all the baby's nutrition is coming from the breast. Doesn't matter if it's pumped or if it's directly from the breast, but all nutrition is coming from the breast. Just exclusively breastfeeding, and you're not having periods, then that's pretty decent birth control. I put it in the category of kind of like condoms, so 85–90% effective, somewhere in that neighborhood. But one thing really important to understand is that the minute you start to wean or the minute you start to supplement, you can ovulate and get pregnant before you even have a period. And I've seen that happen so many times I can't tell you. So the minute you're not exclusively breastfeeding, the minute you start to wean or supplement, all bets are off. So just keep that in mind. All right, let's see. Jamie, diagnosed PCOS in 14. What are the chances of conceiving naturally? Just lose weight. Yeah, so there's a pretty good improvement in fertility rates if you lose 10 to 15% of your current body weight if you have PCOS. So I don't have a, sorry if I bumped into the mic there. I don't have a number that I can quote you, but there are studies that show that that type of weight loss does lead to improved fertility outcomes. So 10 to 15% is a good goal to have. Well, I keep bumping that, sorry. Let's see. Okay, Megan is what are treatments for PCOS? A big one I was just talking about, which is weight loss, and it really does make a difference. There are studies that show putting someone on a birth control pill for 2 to 3 months to regulate their cycles, plus aerobic physical activity with a goal weight loss, like I was saying, 10 to 15% is enough to help. So that's a big one. And then if you're doing all the right things and you're not ovulating, not getting pregnant, then typically ovulation induction is the way to go. Usually Clomid or Femara are the two most typical medications used. Those are both oral medications. And if they're not working, sometimes you add metformin. The evidence is not as strong for metformin and PCOS for fertility as it might be for other PCOS symptoms. Might help you lose a little bit of weight. Mostly from some of the GI side effects that you can encounter with metformin. But it does help for some people, especially those who are not ovulating on Clomid. You might consider adding metformin in that situation. And that's about it when it comes to the sort of first-line treatments for PCOS. Beyond that, you start talking about, if we're talking about fertility specifically, then you may move on to like injectable fertility drugs and things of that nature. So that's kind of the long and short of it. Let's see, Amara, is it okay to eat okayed meat when pregnant? I'm saying maybe it's supposed to be cooked. Cooked meat is fine. You want to watch out for deli meat. So deli meat that's, say, cold in your refrigerator, you wouldn't want to just put it on a sandwich and eat it. You want to basically recook it. You want to be sure that the meat is thoroughly cooked up to a temperature where it's steamy hot. That would kill any potential bacterial contamination. We're mostly concerned about Listeria, because that's bacteria that can cause infection that leads to pregnancy loss, stillbirth, and miscarriage, and things like that. So, but other meats, like say you made, hamburgers or whatever, it's fine, as long as it's cooked. So I think that was your question. Hey, Island Girl, how's it going? Yeah, I'm a little bit early today, but thanks for the welcome back. Let's see. So Megan was saying she thought PCOS causes weight gain. No, it's kind of the other way around. So weight gain is a risk factor for PCOS, we think. So it seems to be more that obesity is a risk factor for PCOS, not that PCOS causes obesity, we think. Oh, smoked meat. Smoked meat, it actually, okay, yeah, different than cooked meat. Smoked meat there may still be some concerns for Listeria contamination. So I would kind of follow the same type of guidelines that I was talking about for deli meat. So if you recook it, if you nuke it, you might not get it thoroughly cooked, but if you stick it on a griddle or, a frying pan and cook it up that way, then you should be fine. But there are some concerns about like, pepperoni and things like that. If that's a smoked meat, I don't really know. But I would take the same type precautions. Let's see. Corbin, 38 weeks, space easy drop, last couple of days, normal for movements to feel less frequent, strong when that happens, still feeling movements. Yeah, so really common for folks in the last few weeks of pregnancy to say they don't feel as much movement as they used to. And I think that's pretty common sense just from perspective of babies getting bigger, there's less room, you can't feel them as much. But you should always be able to feel a certain kind of minimum amount of movement. So my general guidelines to someone are if you can feel 10 movements within 1 hour, one time per day, then I think you're still good. So that's my basic kick counts talk. So if you're getting that, you're good. And if not, I'd recommend getting checked out. Kimberly said, moving to the area in 2 weeks, wondering if we do water bursts. So there are options for what we call water immersion in the first stage of labor. So before you are completely dilated and start pushing, there are tubs at both hospitals that's doable, and there is evidence from some pretty good studies that it can reduce the risk of moving on to using an epidural for pain relief. So I definitely endorse that. I think there's good evidence. Now, as far as like delivering the baby in the tub, we're not doing that. Our college recommends that babies be born on land. And the reason is there have been some drownings reported from actual water bursts where baby was delivered into the tub. And there's definitely sort of an internet group of people who believe that being born into the water is normal and natural, and you're in a bag of water, so what's the big deal when you're born? Well, babies often take a big gasp as soon as they're born and they're trying to breathe. And all their plumbing is changing in their lungs to divert flow away from the placenta to their lungs. And so if you then flood the lungs with water, that's the concern that there might be increased risk of drowning. So you can labor in the tub, but we don't actually deliver the baby in the tub. Let's see. Heather, can you be induced without an epidural? Yeah, you can. It's certainly an option. And, you can kind of try to go slower and easier. For some people, that works out just fine. Sharp pains, then run up your cervix. Should you be concerned 35 weeks? No, I mean, I think as long as the baby's moving good, there's no bleeding, you're not feeling like you're in labor, then that's probably just normal stuff. Let's see, Jamie, best diet to be on when you have PCOS? Yeah, it's a good question. And the one thing for sure to avoid is keto. Keto is very popular, right now for weight loss. And I think there's, some decent evidence that keto diets do help you lose weight. But there's also evidence that a person who's doing the keto diet and then gets pregnant has a baby that's now at increased risk for spina bifida. And it might be just due to folate deficiency, because when you restrict all grains, then you wind up having a very low folate diet unless you really eat tons and tons and tons of green leafies or take a high dose of folic acid. So I'd avoid keto. And I think just, avoiding or reducing refined sugars definitely is good advice for anybody, and certainly somebody with PCOS. But I'm not a big fan of these diets that just say, no, none of this, no that, no that. Other than no fast food, that's pretty good advice. Trying to avoid processed foods is good advice. But I think, if it's lots of fresh fruits and veggies, fresh lean sources of protein, reasonable amounts of dairy, then I don't think that it has to be no dairy, no sugar, no carbs, that kind of thing. Let's see, having some questions pop up on YouTube. Talk about birthing big babies. Some say C-section, some try to labor. Yeah. So Rachel, it's a good question, and it's a difficult one to answer. So I'm just going to give you the talk that I would give somebody in the office. So if, let's just say I was suspicious that someone had a big baby and we did an ultrasound and I got an estimation of weight that was larger than average, then I tell them these things. And this is somewhat evidence-based and it's somewhat just opinion and experience. So the first thing I tell everybody is, sorry, I'm banging the microphone. I try not to freak out too much about it, because first off, ultrasounds are not entirely accurate when it comes to estimating fetal weight. So the first thing I tell everybody is you don't really know how big the baby is until we can have the baby and we weigh it on the scale. That's how you really know. So realize that ultrasound is only so accurate, maybe plus or minus 10 or 15% really, even at full term. So you have to have a pretty high number before you get really concerned about it. So if you're talking about a mom who's not diabetic, so doesn't have diabetes pre-pregnancy or also doesn't have gestational diabetes, then if you get up above 10 pounds, then you can start to have that thought, well, if you take a pound off, it's maybe 9 pounds. That's possibly still reasonable for a lot of people to deliver, but it does start to make you worry a little bit. So at least have that conversation. Try to have some estimation of the patient's pelvis size, which is really difficult, but at least a pelvic exam to say, feels like a reasonable pelvis to have a decent sized baby. And that's purely just clinical judgment. There's no science behind that. They used to do x-rays and try to measure different parts of the pelvis, and it's just not very practical. A really simple rule of thumb that may sound crazy, but I swear is pretty predictive, is most people can deliver their shoe size. So we talk about shoe size a little bit when we start. Someone's got a 9 or 10 pound kid on ultrasound and they tell me they wear a 10 or 11 size shoe. I'm really not that worried about it. You can pretty much deliver your shoe size, and most people can beat it by a pound. I don't think it necessarily works if you wear like itty bitty shoes, like 5s, but people who have kind of normal size feet in that normal range, then I think it's pretty reliable. So I look at those kind of things. We talk about the pros and cons. If you get certainly well above 10 pounds, it's not wrong to start thinking C-section, purely just because you worry about potentially the baby either getting stuck in labor or having a difficult delivery, having injuries. Some of those can be permanent. Some of them can be life-threatening. So you got to at least think about it. But I try really hard not to freak out about it. So hopefully that's a helpful discussion. And if you have diabetes, pretty much 10 pounds would be the cutoff, 4,500 grams. And most people would say just have a C-section, because we know those babies tend to be broader shouldered and higher risk for shoulder. Sarah says, anterior placenta, will baby likely be born sunny side up? No, not necessarily. So the placental location really doesn't have much to do with the baby's birth position, so I wouldn't worry about that. Okay. Let's see. If someone's having periods on average 35 days or longer and not getting cervical mucus, is it probable? I'd say it's much more likely that you're not ovulating regularly for sure. So that's one where maybe do some ovulation tests if you haven't already. You didn't say. And then maybe think about Clomid to help you ovulate more regularly. Let's see. Ovulate with Clomid, cycle day 18, positive ovulation kit. Yeah, it doesn't necessarily mean anything like how long it was positive for. If you saw a positive, it's positive, so I wouldn't worry about that. Let's see. Rachel, first round of Femera and second pill out of 5. Notice some mucus changes, positive cave. It's probably a false. It's probably a false positive, because you probably wouldn't ovulate that fast. You didn't say like what cycle day you're on, but it's probably false positive if I had to guess. Okay, Shayna, what week would you induce for a Vbac? Well, everyone's different on that. I mean, it's preferable for labor to start on its own, but not everybody's in a situation where that's practical. So, if you have other complications of pregnancy, so maybe, high blood pressure, diabetes, or sometimes other factors that necessitate induction, it's certainly very reasonable to consider induction in those situations. And it's not wrong to consider induction electively. We just know there is some evidence that induction of labor increases the risk a little bit for uterine rupture, so you have to be a little bit more careful about that. But it's not an absolute, and the week for induction just depends on the indication for the induction. So elective inductions are 39 weeks and beyond. But there are medical indications that might go as early as 37 or 38, or sometimes even sooner, depending on the situation. Let's see. How likely is it to be able to tell baby's gender at 15 weeks? Depends on the baby. But if they're cooperative, it's usually a pretty good shot. Let's see. Can you take Clone without your period so I get pregnant? Yes. Yeah. So there's actually evidence that taking progesterone, you said Provera, which is a type of progesterone, before the Clomid actually reduces the chances of getting pregnant. So I talk about that some in my Clomid and Femera video. It's on my YouTube channel. You can check it out. But so I just, basically do a pregnancy test, make sure the person's not already pregnant, do an ultrasound, see how the lining of the uterus looks and the ovaries look. And if things look like really nothing much is happening, then the cycle day really doesn't matter so much. And I'll just start the I'll just start the Clomid. Let's see. Megan, is facial hair a big sign of PCOS? Do you use spironolactone? Yes. Is it a sign of elevated testosterone? Yes. It's a sign of PCOS. Big, little, I don't know. I mean, it's kind of one of the signs of PCOS. And spironolactone can help for that. Let's see. C-section 11 years ago, does it mean you're not at risk for scar? No, the risk is always there. It's about 1% is what we quote for anybody, regardless of when it was they had their C-section. So there's always a slight risk. Let's see. Jenny said, we gave gender a couple days ago. How likely is that to be wrong? Not very likely. Can't say 100%, obviously, but also I usually give people some estimation of how strongly I feel about the results. So maybe I told you. Hey, Kayla, how's it going? How's the baby? Let's see. I think I'm all caught up. Let's see. Tori woke up 20 weeks with a rash on your arms, gotten worse. Hard to say. Rashes can... I didn't tell us. Well, then I guess I wasn't wrong. Or you mean I didn't tell you how strongly I felt about it? I don't know. Guess we'll see when you come back for your targeted. But I usually, if I'm not feeling good about it, I usually say something. Tori, rash on your arms. Hard to diagnose rashes over the internet. It's definitely one of those things, if it's popped up and it's bothered somebody to get it checked out, it's probably not an emergency. But it's one of those things. It's one of those things that's hard to know over this type of forum here. Yeah, how strongly? Yeah, I must have felt pretty okay about it then. Okay. Let's say, oh, you did a gender reveal? Oh, I must have felt pretty good about it because I would have said something. If I know you're doing a gender reveal, then I usually tell people. Let's see. Yeah, I think I'm all caught up. Cool. All right. I think I'm good. Okay, you guys, if you have questions, put them in the chat. We'll keep this going for a little while longer. Let's see. Everything still seems to be working okay. I haven't gotten any comments last. Oh, here we go. Just did a scope over a year ago. Big adhesion on your uterus. What's the potential of that causing complications during your pregnancy? Hard to know from the description that you were telling me, but nah, I don't. It's unlikely to be a big problem. It's something that we could look back at your operative report at your next visit and talk about it a little bit more then. But it's kind of a vague comment, so hard to really know. Let's see. Megan, oh, you got a phone call, missed my answer. Oh, okay. Well, the question was facial hair and sign of PCOS. It is a sign of PCOS. Yep, that's okay. And it's related through testosterone, and spironolactone is very reasonable to use for that. So yeah, I think that answered your question. Cool. Let's see. Monica, what are your thoughts about eating during labor, not saying a big meal, but like snacking? Yeah. So there's evidence that that it's perfectly fine, that there's no higher risk of complications. Anesthesia in some places is still pretty anal retentive about it, but there's evidence in the literature that that it's fine. So I don't think it's a big deal, particularly if it's kind of mostly cleared, not like steak and potatoes. So, like carbohydrate drinks, Gatorade and sugary snacks and stuff like that are not real particulate are probably fine. The problem has been just convincing either the anesthesia in the hospital or the lawyers of hospitals to let policy change. But, if I walked in the room and someone was drinking a Gatorade or whatever, I wouldn't worry about it. And so it sort of depends on which hospital you're at, but they've gotten a little bit more lenient over the years. From when I started, it used to be like just nothing. So I think it's gotten better. Let's see. Does lightening crotch mean your cervix is dilating? No, it doesn't. It's most commonly, either just some pelvic muscle pain or symphysis pubis separation, or just the baby kind of dropping into the pelvis. but it doesn't mean your cervix is dilating. I mean, your cervix could be dilating, but most people have no feeling coming from that, so they wouldn't know based on the sensation that they were having. So I think they're unrelated. Let's see, Shana, what's parvovirus? How can you get it? It's a respiratory virus. In kids, it causes like hand, foot, and mouth. So it's a fever and a rash, usually on their hands and their feet and their mouth. And it can cause some problems for pregnancy. It's spread through the air. So you want to avoid anybody who had it and just not let them sneeze in your face, that kind of thing. If it's your kids, it's really hard because it's hard to not catch stuff from your kids, but as much as you can, kind of respiratory isolation. Kayla, showering, want to take a bath? Yeah, it's probably fine at this point. It's been long enough. So I think you're probably fine to take a bath. I recommend not taking like a soaking bath for the first couple of weeks, especially if you had like a bad tear. But at this point, you're probably good. Okay. Well, wait a couple more minutes, see some other questions. Let's see. How bad is changes in the litter box? Well, if you have a cat that's ever been outdoors, there's some chance that the cat picks up toxoplasmosis, which is a parasitic infection. Cats are one of the animals that it goes through, and it's excreted in their feces, so that's why the litter box is a thing. So if your cat's ever been an outdoor cat, it's a potential, so I just wouldn't do it. If your cat's never been outdoors and never been around, never boarded with other cats or whatever, then it's probably not a big deal, but I think it's a good excuse not to have to do it. And if you have to do it and you do have a cat that's like indoor, outdoor, then I'd wear a mask and I'd use gloves and wash your hands and all that. Because just that act of sort of scooping, there's always that dust and junk in the air. Toxoplasmosis can basically be in that aerosol, can be aerosolized. So recommend against, but if the cat's never been outside, it's really not that big of a deal because they have to be outdoor cats to have been exposed. So it's okay to pet your cat too. I always say that. Just don't eat the poop. Let's see, I missed one back here a ways. Penny, stopped breastfeeding a month ago. Still don't have your period. Is that a problem? No, it may take a couple months. So I would expect that within a couple months, your regular periods will come back. Oh, hey, Bethany. How's it going? Let's see. Shayna, one rosy cheek since getting pregnant, and you Googled it, it says parvo. Nah, I don't think that's anything to worry about. Yeah, it's a pretty wicked rash. Let's see. Should twins be delivered before 37 weeks if the mom has cholestasis? Typical around 30. So 36 to 37 is the typical time frame for cholestasis, and the twins part doesn't really change that. So cholestasis, again, 36, 37 weeks is typical time frame for delivery. And then there's other reasons why twins might need to be delivered, but it's got nothing sooner, but it's got nothing to do with cholestasis. Let's see. Does the days take Clomid matter? Took it 3 to 7. It doesn't really matter. Doc said letrozole won't help you with ovulation. I don't know. I mean, Clomid or letrozole are both fine. So if you didn't respond to the letrozole, perfectly reasonable to try Clomid. There definitely are people that respond better to one than the other. So I think that's reasonable. But whether you did it starting on day 3 or starting on day 5 doesn't really matter. Let's see. Monica's talking about some contractions. Now they've stopped. Happening randomly, I guess. But, okay, I got to click this to see. Are pretty strong. About an hour and a half away from the hospital. I always recommend, like, if they're going every 5 minutes for 1 hour, go to the hospital. And if they're less than that, I can't tell what you said. They're just randomly now. It's hard to know over the phone or over the internet or whatever. Bottom line is if you're concerned, you can always go get checked. And I know it's a little bit of a drive, so it's hard to know for sure. That's kind of part of the deal, unfortunately. And also, I forget what your cervix was last time, but Yeah, kind of same answer. If they get to every 5 minutes for an hour, for sure, go to the hospital. If they're every 10 and you're worried, I'd go. If they're not at least every 10 minutes, I wouldn't worry so much about it. But if they're strong and you're worried, then my advice is just go get checked out, because better safe than sorry. Let's see. Haley, morning sickness is going away, but still nauseous at night. B6 Unisom helps, but doesn't take it away. Think I'll ever feel better? Hard to know. Hard to know. Some people are just nauseous the whole time. So hard to predict the future. Fingers crossed. I guess we'll see. That's a tough one. Let's see. Jenny, got a headache. 14 hours, blah, blah. What can you do? Trying to get more painful, more sensitive, more nauseous. I mean, if it gets severe, you can go to the ER. They can always give you meds there that are kind of like controlled substance type things. I always recommend Tylenol, a little bit of caffeine. And then, but if you said allergic to Tylenol, I'm not sure. And if you're nauseous, maybe just going to the ER. And they can, often we'll use like Phenergan. They can give you an injection. Or Compazine, something like that. And those are safe in pregnancy. So I'd say if it's getting worse, then that'd be what I would suggest. Sorry about your headache. It's a bummer. View on water births. I was just talking about that a minute ago. There's a video on my YouTube channel that talks about that in detail, but the gist of it is it's fine to be in the tub for labor. I don't deliver in the water. There's evidence of higher risk of babies drowning if you deliver them in the water than if you deliver them on land. So water birth per se, not so much, but labor in the tub is fine. And there's evidence that it reduces the chance of needing to have an epidural. So I think if that's your goal, it's a good thing. Let's see. Got a tooth that's messed up, a large hole and it bleeds. Any recommendations? Yeah, go see a dentist. I don't know anything about teeth, but if it's bugging you, I'd go see somebody that does. That's for sure. Let's see, Sarah, how does someone get gestational diabetes? Yeah, it's probably, to some extent, there are risk factors. So ethnicity matters. So like Native Americans have a higher risk. People who are Hispanic have a higher risk. Weight is a risk factor. So if you're overweight, but there are people who are none of the above and still develop gestational diabetes. So I think that's kind of random, as you were saying. And it has nothing really to do with your diet. So you can't necessarily give yourself diabetes, other than if you gain too much weight, that might increase your risk. So it's more to do with the placenta at that point. So the placenta makes this enzyme called an insulinase, and it dissolves insulin, and it makes mom's sugars get higher, and that's how the glucose gets across the placenta. So, excuse me, it's a good thing to have that going on. That's how the baby gets their glucose. But if you just so happen to have a placenta that's cranking out insulinase, and if you happen to be a little bit insulin resistant, then that's how diabetes develops. So it can certainly be random. It doesn't have to mean that you've done. It doesn't mean you did anything wrong with your diet, probably. Weight is a risk factor, I guess. Let's see. When do you prefer to test for gestational? So routine testing for gestational diabetes, 26 to 28 weeks is pretty typical. If you have twins, it's often recommended to test earlier because, again, sort of twice the placental mass, you may have a higher risk and you may be able to pick it up sooner. Sometimes, with twins, I'll test even as early as 20 weeks. If you have a history of gestational diabetes, I do test earlier. I even test people for signs of elevated glucose at the first pregnancy visit with like a hemoglobin A1C. And if that's normal, I tend to test at 20 and then 28. But if you have no history, you don't have twins, just normal pregnancy, then I test around 28. Let's see. Trying to lose weight, nursing full time. Can I use Thrive? I don't know what Thrive is. But if it's a supplement, then, it's hard to know what's in those things. The problem is they're not regulated. There's often a lot of caffeine and who knows what else. So I don't necessarily recommend any particular supplement. I don't recommend supplements in general. Just, the usual stuff. Let's see. Elizabeth, when exercising, ignoring. All right. No, it's not a big deal. do people just die when their heart rate's at 100%? No, that's a great question though. And I'm assuming you're asking it like in a pregnancy context, because there are lots of recommendations just kind of floating around like, oh, you can't go above some random heart rate, 140 or whatever. It's completely arbitrary. You know, there's evidence in like elite athletes and people who are Olympic marathoners that continue to train, you know, through the whole pregnancy and, you know, even participate in races and whatnot. So it's more about, I think, you know, what's your current state of physical condition. So if you have somebody that's like, yeah, I just did an Ironman last week, I'm really not going to tell them to stop at all. And if you have someone who's been a complete couch potato, I'm not going to say go do an Ironman next week. So sort of a gradual progression is perfectly fine. The heart rate is really arbitrary, and most people can't just go out and nail, you know, 80% of their heart rate for very long. You'll stop because you'll get to your lactate threshold and your muscles will make you stop. So it's not anything to really worry about, and there's really no good data that any particular heart rate is good, bad, or indifferent for the pregnancy. So generally speaking, you're just kind of listening to your body is the best advice I have there. Let's see, what's the best painkiller with no prescription? Okay, well, if you're pregnant, you shouldn't take ibuprofen. You should stay away from all non-steroidals. That's ibuprofen and naproxen primarily. So you just want to use Tylenol, so acetaminophen. That's what you take for pain when you're pregnant. Let's see, Amanda, 3 kids, 2 miscarriages, 4th kid now, 2 chemical pregnancy. It happens. And there is a video on my YouTube channel about evaluation of recurrent miscarriage. And so if you're curious, I would check that out. And it kind of talks through all of the things that I would do. And, you know, probably the answer for you is you're probably fine because you've had lots of healthy kiddos. But if you're curious to know kind of, well, what things would you evaluate, go check out that video and it'll answer the question for you. Rachel, let's see. 3 days late, day 25, 6 pregnancy tests, all negative. Probably too early to say definite. So, you know, I generally say test around day 35. And if you're still negative, then that's pretty conclusive at that point. But even then's no guarantee because it all depends on when you ovulated. So, but I'd say at the moment it's too early to call it. Let's see, PCOS, Hashimoto's, overweight, working on that, good. Anyway, worried about miscarriage rate. Will it be very high? Is it? Well, PCOS doesn't necessarily increase your miscarriage rate. Hashimoto's maybe a little bit if you have a abnormal TSH and positive, they're called TPO antibodies. There may be some higher risk for that. The main thing you can do is just have a normal TSH level and a normal free or normal T4. So if those levels are normal, then you're doing everything you can to optimize the situation with regard to your thyroid. And outside of that, I wouldn't be too worried about it. Let's see, Stephanie, is the Mcinnis shot horrible? No, it's a shot, kind of hurts, ouch. But I mean, you know, for most people, not a big deal. You may get some sort of injection site reactions. So because the progesterone is suspended in some sort of oil, sesame oil, for example, but there's others. Excuse me, and some people react to the oil and it causes like a local injection site reaction. Tenderness, rash, you know, things like that. But outside of that, for most people, not a big deal. And if you have a history of preterm birth, then progesterone injections are definitely a really important thing to do. There's good evidence that it reduces the risk of recurrent preterm birth, so I would definitely recommend them. But if you're having a problem with a particular type of shot, then I would suggest talk to the pharmacist who's giving it to you, because they can give it to you in a different type of oil. And so if you're having a problem with one, say sesame oil, they can change it to, I don't know what the other one is, canola oil, I'm making it up, but some other kind of oil, and you might do better. Is horse riding safe in pregnancy? I wouldn't recommend it, say 3rd trimester, where if you take a bad fall, it could cause like placental abruption that could lead to preterm birth, things of that nature if you fell off the horse. 1st trimester, I don't think it's any big deal at all. The baby's well protected inside the pelvis. So that's not a big deal. And then the middle trimester, it's kind of like, you know, use your own judgment. How chill is the horse? If it's your horse that you've known forever and it's never given you a minute's problem, I'd be less concerned than some random horse. But we all know no matter what, horses can get spooked and do weird things. So there's always some risk. So I definitely wouldn't do it 3rd trimester. First trimester I think is fine. Let's see. Kimberly had anatomy scan this week. Doctor wants to have another one. Check growth, gastric sleeve. Is this able to? Yeah. Yep. That's no problem. And it's certainly reasonable to follow the growth if you have a history of bariatric surgery just to make sure that the baby's growing good. So yeah. Let's see. How do you feel about pregnitude OTC fertility supplement? So I was just kind of answering that supplement question a minute ago, Amanda. And the gist of it is there's no data that any supplement is any better than nothing, for one thing, because they're not regulated, and there's just not good evidence outside of, say, FDA regulatory processes that any of these things are of any benefit. So you ought to take a multivitamin that has, at least 400 micrograms of folic acid, because that's going to reduce your risk of spina bifida in the baby. And outside of that, there's just not good evidence that any supplement is going to improve your fertility. So I don't really recommend them. I don't think they're bad, but like I said, there's just not good data that they're good or that they're helpful. So, why spend your money? That's kind of the way I look at it. All right. Let's see. We'll give us a few more minutes and see if any other questions pop up, and then maybe we'll call it a day. But we'll give you guys a couple more minutes, see if any other questions pop up. Okay. Alrighty, well, we'll give us another minute or two. I'm not seeing any other questions coming on. There are a couple people jumping on, so I'll give you guys a second. If you're just jumping on, welcome to my Facebook Friday live stream answering questions. If you have a question, stick it in the comments real quick and I'll answer it. Probably going to wrap this up here in a few minutes if no other questions come on the chat here. So if you're just waiting to put your question in, don't be shy. Go ahead and pop it in there. I'm just going to roll back through here and make sure I answer everybody's questions before. I think I'm all caught up. Cool. Okay, here we go. Annie. Should there be any worry if there's light bleeding 2 days after a period ends? No, not really concerned. So if you're pregnant, maybe a little bit of implantation spotting, something like that. But outside of that, it doesn't really sound like any big deal. Same time Friday. Yeah, so I'm typically kind of a Friday streamer. I've been slacking for the last month or so. We've been out of town a lot and traveling and whatnot. But yeah, Friday afternoons are kind of my time. Usually around this time, 2, 3 o'clock. Let's see. How many months after myomectomy should you wait to try to conceive? It's a good question. Probably at least ought to wait 6 months. It is honestly arbitrary. There's not good data. There's no good studies that really guide us. And I'd say conservative answer would be like a year, but that's a long time to have to wait. So I would say at least 6 months is as good as anything. Stephanie, 2 preemies. Yeah, Mcinnis definitely recommended. Yeah, for sure. Cool. And the big thing to know about the myomectomy is, where was it in the uterus, and was it like a full thickness type incision? If you had a full thickness incision at the fundus of the uterus up at the top, then C-sections are recommended for those folks. I don't know if your doctor told you or not, but that's important to know. If it was one that was removed through the hysteroscope, like up through your cervix with a camera, there's no concern about at all. The only concern is if you make a big incision at the top of your uterus, it's kind of like a classical C-section. We worry those may be much higher risk for uterine rupture in labor, so that's why C-sections are recommended. Let's see. Adriana, miscarriage in August, chemical pregnancy February. Is there any quantifiable probability? Yeah, it's hard to know. It's hard to know. But if you've had a couple pregnancy losses and you haven't had any live births, it's certainly reasonable to do an evaluation for recurrent pregnancy loss. And that is discussed in a video on my YouTube channel. So just jump on the list. I think it's in like the pregnancy trying to conceive playlist called Evaluation of Recurrent Miscarriage. So I would maybe start thinking about doing the things that I talk about in that video. But it's hard to give you a number like, well, if you've had 2, what's the chance of a third? That is a difficult one to answer. Let's see, question here about can you take resveratrol? I don't know what resveratrol is. I'm assuming it's some kind of supplement, which I've already kind of had that supplement discussion here a couple times. Robotic. Yeah, still the question is where was the fibroid? What was the depth of the incision? You know, was it more than 50% of the myometrium or not? Those are the kind of questions that you'd want to ask the doctor who did the myomectomy, because that's going to help you answer, is it okay to try for a vaginal birth or not? And maybe they just told you straight out if it was okay or not, and that would give you your answer. Cool. Okay. Well, maybe we'll give you guys about another minute. We'll see if anything else pops up here for questions. Just checking the stream here. Looks like it's hanging in there. Let's see. Switched medical team, started the process of investigating. Good. Excellent. Well, best of luck with that, and hopefully they'll find something. The frustrating thing is that, you know, you go through all this stuff and don't find anything, and then it's like, well, so now what? And in those situations, my answer is always the same. Just keep trying. There are things that are difficult to detect through even like chromosome analysis. So microdeletions within the chromosomes are hard to pick up on standard karyotypes, and they probably explain a lot of recurrent miscarriages. You know, if you're 3 or 4 in and still no luck, then sometimes my recommendation is go see a fertility specialist. Think about in vitro. It may be an egg quality issue. And the benefit of in vitro is if you can get say you do an in vitro cycle and you get like 20 eggs, you may find that like 16 of them don't make it through the process and 1 or 2 are good looking embryos. And so basically you just compress like a year or 2 of trying into one cycle. It's more expensive, but it's often more efficient if you have recurrent pregnancy loss that's unexplained. So just something to think about. Rachel, varicose veins a problem? No, they're really common. You can have them treated after delivery, but in and of themselves, not a big deal. They do increase the risk of blood clots a little bit, as does pregnancy. So support socks maybe reduce that risk a little bit, but outside of that, not a big deal. Amanda, what state? Live in Utah. So it's Ogden, Utah is where I am. Let's see. Amy, if you're trying to conceive and don't have a regular period, what do you use to start a period? So, Amy, check out, there's a video on my YouTube channel that's called How to Take Clomid or Femara. And so that's what you need. If you're not having periods, you need Clomid or Femara. There's no evidence that like taking something to start a period is going to make it so you ovulate. So that's kind of old school. And I discussed that in that video. So go check that out. And if you have questions after that, put it in the comments of that video and I'll be happy to answer them. All right, Island Girl, still trying. Best of luck. Let me know when you do get pregnant. I hope it's soon. Yeah. Can you ask anything? Yes. We'll see what it is if I answer or not. But yeah, you can ask whatever you want. Okay, let's Saksham. Saksham, where are you watching from? I'm curious. The pressure's on. We're all waiting. On Facebook, you don't know this, but on YouTube, someone asked, can I ask anything? So I'm waiting to see what the question is. If you guys have a question on Facebook, stick it in the chat. Probably a couple more questions here and we'll call it a day. Waiting patiently. The suspense is killing me. Okay. I'm waiting. No questions so far. You can do it, Saksham. You can ask your question. I'm ready. Hopefully my feed's still working. Looks like it's still going. We're all waiting. We're ready. We're all ready. What's the question? Adriana, thanks for all the videos. Oh, you're welcome. Thank you. I enjoy doing these. It's fun. So thanks for jumping on. Thanks for your questions. Thanks for watching. Typically kind of a Friday afternoon deal. Not every Friday afternoon, but a lot of Friday afternoons. Let's see. Karina, how do you feel? Oh, you missed it. We were talking about keto earlier. Okay, so keto, if you're trying to get pregnant, is a definite hard no. And I talk about it. There's a video on my YouTube channel that that goes into detail. But the reason it's a hard no is that there is at least one study that shows a higher risk of babies being affected with spina bifida in moms who were doing the keto when they conceived. Now, we don't know why, but it's a thing. And it may be that it's all about avoidance of grains, and therefore you're very deficient in folate. If that's all it was, then you probably wouldn't worry so much if you just took a bunch of folic acid, and you're probably fine. But it may also be something about that ketotic state, that when you have ketones circulating in your blood, because you're not supposed to have ketones circulating in your blood normally, that may in and of itself be what we call teratogenic. So it may be that ketones actually are the thing that cause the birth defect. So basically keto is a no if you're trying to get pregnant. Good question. And it's on my YouTube channel if you want to go watch the video. Let's see. Can you conceive with low sperm count and low quality sperm? Yes, but it is harder. And so inseminations are often recommended when that's the situation. So if you have low numbers, poor motility, things like that, then it's harder to get pregnant spontaneously. And it might be that inseminations help, so we'd typically recommend that as the next step. If that's not cutting it, then often in vitro with what we call ICSI, intracytoplasmic sperm injection, is the way to go. And that's where you run an IVF cycle, you get the eggs out of the mom, you take the sperm from the dad, and you actually inject the sperm into the egg with a little robotic controller thing, and that'll fix it. Let's see, Rachel, no PMS symptoms at all, no period besides pregnancy. What else could it be? Just sort of ovulatory dysfunction. So ovulatory dysfunction just means you're not ovulating regularly. Doesn't mean it's oh, you're saying no period besides pregnancy. What could it be? Yeah, just some sort of ovulation dysfunction. So it's worth getting checked out. Thyroid disorders, elevated prolactin, things like that can do it. PCOS can do it. So there are reasons that you would not have regular periods that are medical. And so those are the kind of things that we think about checking. Hopefully that answered your question. Let's see, how long we have hot flashes when you start menopause? It's a good question, and everybody's different. It might be months, it might be years. There's no way to predict how an individual person's sort of menopausal transition through life is going to go. So sorry, I don't have a good answer for you. Okay. Well, Shaksham didn't ask the question. We were all waiting. It's been a minute. If you're still on there, put your question in there and we'll answer it. Otherwise, we're probably going to call it a day here. Perimenopause. Unlikely if you're not having hot flashes, night sweats, things like that. But again, it's something that's testable. So, perimenopause is typically kind of more like, late 40s or early 50s, somewhere in that neighborhood. Unless you have a family history of early menopause, then I wouldn't be too worried about that. Okay, well, I think we've been on the stream for a solid hour here. Let's see. It has been 1 hour straight up. Okay, cool. Took the trigger shot, no period, negative test. So typically around day 35, I'd say do a pregnancy test. And if it's negative, then 47, yikes. Yeah, it might be. Then we'd say repeat ultrasound in the office, Annabelle. And if things look quiet, just kind of go back at it with the next round. Could you have tested too early? You didn't say what cycle day you were on. But if it's beyond day 35, I'd say then time to follow up in the office. Hey, Susie, thanks for liking the video. I just saw that pop up. Okay. All right, guys. I think questions are kind of dying off, so I think we'll wrap it up there. Thanks to everybody who's watched today. Thanks for your questions, because I got nothing to talk about if you don't put questions in the chat. So I think we'll call it good for today. Maybe we'll see you next Friday. I'm not exactly sure what I'm doing next Friday, but if I'm around, I'll be on here somewhere in that 2 to 4 p.m. neighborhood. And thanks for watching. We'll catch you next time. Have a good weekend. Thanks, everybody. And Annabelle said, today's 15 days after trigger shot. I'd give it a couple more days, Annabelle. And then if it's still negative, then like first part of next week, come see us in the office and we'll do ultrasound. All right. See you next time.